A little background for our clinical appraisal. It revolves around lateral elbow pain and more specifically lateral epicondylitis, which is a really common source of consultation for non-traumatic elbow disorders. It is often treated with cortisone injections, NSAIDs, and other physical therapy interventions. However, tendinopathies and more specifically lateral epicondylitis have been found to have great improvements when treated with low-level laser therapy. So our clinical question is, what are the effects of using low-level laser therapy in reducing pain and improving grip strength in patients with lateral epicondylitis compared to receiving low-level laser therapy or placebo treatment?
For our search strategy, the terms that we used were patients with lateral epicondylitis between the ages of 30 and 60 years old, the intervention of low-level laser therapy compared to no low-level laser therapy or placebo treatment, with outcomes of visual analog scale and grip strength assessment. And these are the sources we used.
Here you can see our inclusion and exclusion criteria. For the big inclusion criteria, what we really wanted to focus on were patients with lateral epicondylitis, as well as the outcome measures we were looking at, so grip strength and the pain rating using the VOS scale. And then finally, we also had to have it compared to a placebo or a control group.
From our search, we found 9 possible studies related to the clinical question. 3 of the studies met the inclusion criteria and were utilized in this appraisal. They were randomized control trials and they classified as level 1B evidence.
As you'll see here in the upcoming slides, 2 of our studies showed that active low-level laser therapy treatment had significant improvements on our 2 outcome measures. The other study also had improvement, but it only showed it in long-term in patients. In the short term, it did not show significant improvements.
Eminent et al. Carried out a randomized control trial in which 49 patients with lateral epicondylitis, or 50 elbows as one patient had bilateral lateral epicondylitis, were randomized into one of 2 groups, active low-level laser therapy or placebo low-level laser therapy. As you can see, there were many inclusion and exclusion factors. The primary outcome measures were the VOS for assessment of pain, tenderness over the lateral epicondyle, DASH questionnaire, the PRTEE test, and the pain-free grip strength, as well as the NHP questionnaire, all of which were assessed at baseline, at the end of 3 weeks of treatment, and when the 12th week of treatment ended. The main findings of the study were that at the 3-week evaluation, both groups showed significant improvement on all outcome measures compared to baseline. However, no significant difference was found when comparing the 2 groups. At the 12-week evaluation, both groups again showed a significant improvement on all outcomes assessed. Also, when comparing the 2 groups at this time, the active low-level laser therapy group did show a significant improvement on a handful of outcomes which are listed compared to the placebo group. This study scored a 16 for validity on the consort. The study did well in many aspects such as random allocation and fully defining outcome measures, but could have done a better job describing blinding methods and potential limitations. Overall, researchers concluded that active low-level laser therapy demonstrated significant improvements on lateral epicondylitis patients in the long term, but not in the short term.
Lamb et al. Performed a randomized control trial with 39 lateral epicondylitis patients that were randomly assigned to one of 2 groups, the active low-level laser therapy treatment group and the placebo low-level laser therapy treatment group. Their outcomes that they measured were mechanical pain threshold, maximal grip strength, VOS, and DASH scores. So you can see that they measured the 2 outcome measures that we want. What they found are in the main findings, but ultimately both groups saw significant improvements in outcome measures, with the active low-level laser therapy group seeing these improvements faster. And with comparison, the active low-level laser therapy treatment group saw significant improvements compared to the placebo group. So ultimately the conclusion was that all outcome measures were significantly improved after receiving low-level laser therapy, and the validity score of the article was 14. They had really good random assignment of subjects as well as really detailed procedure for reproducibility. However, they lacked blinding, they did not state specific dates in it, and they did not discuss limitations or possible biases.
Sturgiolis et al. Carried out a randomized control trial in which 50 patients with lateral epicondylitis were randomized into one of two groups: active low-level laser therapy with plyometric exercises or placebo low-level laser therapy with plyometric exercises. As you can see, there are many inclusion and exclusion factors. The primary outcome measures were VOS for pain assessment during various activities that are listed, wrist flexion active range of motion, grip strength assessment, and pain-free weight tests, which were all assessed at baseline, after week 8 of treatment, and 8 weeks following the end of treatment. The main findings of the study were that after week 8 of treatment, the active low-level laser therapy group improves significantly on all outcome measures except for wrist flexion active range of motion compared to the placebo group. At 8 weeks following the end of treatment, the active low-level laser therapy group improved significantly on all outcome measures compared to the placebo group. The specific p-values can be seen above. The study was scored a 19 for validity on the consort. The study did well in many aspects such as random allocation, fully defining outcome measures and procedures, but could have done a better job describing specific blinding methods and potential limitations. Overall, researchers concluded that when combining active low-level laser therapy and plyometric exercises, significant improvements were seen for patients with lateral epicondylitis compared to a placebo.
Consistency between the articles was that they had used the same type of laser device. However, inconsistency was the total treatment time was slightly different between the studies, as well as the energy densities were slightly different. Lamb and Sturgiolis both used an energy density of 2.4 joules per centimeter squared, and that led to seeing significant improvements in our outcome measures. However, Eminent used a slightly lower one because based on the Basford study, they believe that using too high of an energy density doesn't have significant improvements. However, Eminent et al. Also didn't find significant improvements in the short term, but eventually did in the long term. So the results of the 4 studies stated on this slide can help lead to a possible conclusion that there may be an effective range of laser energy density around 2.4 joules per centimeter squared, where too far above that or too far below that may lead to no improvements in lateral epicondylitis.
In conclusion, there is enough evidence based on this appraisal and the collective findings to utilize low-level laser therapy treatment for lateral epicondylitis in the clinic at an energy density of 2.4 joules per centimeter squared, in addition to some type of exercise program. Further research should be focused on determining a range of energy dosage that is both safe and effective in treating lateral epicondylitis, since the current research does not have narrowed values. This would allow for PTs and clinics to provide the best outcomes possible for their patients.
So our clinical bottom line is that there is moderate evidence that suggests that low-level laser therapy as a treatment for lateral epicondylitis patients between the ages of 30 and 60 years old does improve VOS scores and grip strength.